Good morning. I'm just waiting for some more participants to get in. I see 30 on right now. We'll wait a couple more minutes. Okay, good morning and welcome to Medical Grand Rounds. I see 56 participants right now. It seems to have plateaued. I expect that number to rise over the next 5 minutes or so. So you all, I think, know what the ground rules are. Only the panelists can display their video and audio. Dr. Gacioch will display his slides. If you have questions, please use the Q&A function rather than the chat function, and I will be reviewing that section as the talk goes. We will group the questions and ask them live at the end of the presentation. Again, don't forget to send in your CME evaluations if you want CME for this. And if you have any special requests for topics over the fall, email me directly. So I see we're up to 71 participants. We are going to be doing a couple of polls. So Dr. Gacioch has cases and we'll be doing polls to assess your responses, where you'll pick one of 5 responses, and we'll tell you when that comes up, obviously. So I don't think Dr. Gerald Gacioch needs any introduction to this group. He's our Chief of Cardiology and will be speaking today on high sensitivity troponin at Rochester Regional. So without further ado, welcome, Gerry.
Thanks so much, Brad, and thank you so much for allowing me to have the opportunity to talk at Grand Rounds. I think you just called me old, though, but that's okay. So this is what we're going to do today. We're going to talk about high sensitivity troponins and you know, why we are making the change. And this is going to be the first large public unveiling of what the new acute chest pain algorithm will look like. And then as Pratt said, I want to make this as interactive as Zoom can possibly be. So I have 9 illustrative cases, and you're going to get to vote on what you would do with that case. Obviously, it's anonymous. Please vote. The more people that vote, the more fun this actually becomes. And then I'm going to go through relatively rapidly so we have time for Q&A and make it, again, as interactive as we possibly can. So this is our current reality. This is a real patient I had this summer. Julie is 34 years old, presented with substernal chest pain that she said was sharp like a knife. She had the misfortune of showing up to the ED at 2 o'clock on a Friday. Past history, hypertension, morbid obesity, BMI was in the mid-40s, and an anxiety history. Her EKG is displayed there, and as you can see, it was totally normal. The ED did a CT to rule out PE, and it was ruled out. And she got a standard troponin, was very low, and her heart score, which we'll discuss more detail in a little bit, was very low. So she was admitted to OBS, where she ruled out second troponin was bad, but of course, she didn't rule out till Friday night. She sat in OBS Saturday, Sunday. Monday, she had her sestimib, which on somebody with a BMI of 45, almost always is going to show possible apical ischemia. So at that point, we were called, and I saw her 4:30 on a Monday, said she's a good candidate to have a coronary CTA. Got done Tuesday morning, was normal. And she was discharged at lunchtime on Tuesday. So she spent nearly 4 days. And as always happens, she came back 2 days later with chest pain. So that's our current reality. And the reality after we introduce high sensitivity troponins, same patient, same arrival, same past history, same normal EKGs, same negative CT, but her arrival troponin is normal, and her 1 hour troponin delta is normal, and her heart score is still fine. She's home for dinner. So instead of wasting 4 days in our system, she is 4 hours in our system. So the biomarkers for heart damage, again, have evolved over the years. Some people in the audience may be, like me, old enough to remember when ASD and LDH were actually used. My training was during the time when CKMB was the rage, because it had just come out. And when I came to Rochester in 1990, troponins became available. And I was part of the troponin launch here, where we went from CKMB as the marker for MI to troponin. And we essentially made the decision and flipped the switch over a weekend. And since 93-ish till present, we've used essentially the same troponin assay, the same algorithms. As everybody knows, about a decade ago, high sensitivity troponins became available outside the US. In 2017, they became available in the US. And so why do we want to change to this new assay? And it turns out that pretty much all the current literature and all the current US guidelines use high sensitivity troponin. So whenever you're looking at guidelines, it is assumed that you're using high sensitivity right now. Pretty much all the data that you're seeing coming out in the COVID world, it's with high sensitivity troponins. And in my opinion, we're actually a tad late to make the change. The university did this 2 years ago. And so we're a little behind the gate here. The advantage is the why. We can safely and rapidly triage people like Julie. We can detect MIs earlier and get them in the right pathway faster, and prognostication will be improved. So looking at advantages and disadvantages, we're going to be going to a 1 hour protocol as opposed to our current 6 hour protocol. So we will get an answer much faster. The university is using a 1 hour and 3 hour protocol. And I think, what they did was appropriate a couple of years ago while making changes. We have the advantage of time and more studies that are out now. I expect the millisecond we go to this protocol, they revise theirs. We get earlier triage to the appropriate diagnosis and treatment. One of the things that we're doing that the university isn't doing yet is we're combining a risk score. And with the risk score and the rapid troponin, we can, there's data that shows early discharge is very safe. One of the things that we're doing is right now there are dozens of different places where troponins are throughout protocols within Care Connect. We're going to one protocol across all 5 hospitals, across all outpatient sites, and there's potential cost savings there. The disadvantage, obviously change is always hard, and it seems like the world obviously is changing rapidly all the time. Why do we need to endure one more change? So that is a disadvantage. It is a disadvantage that our numbers are different than the university. So people who use both systems unfortunately need to know 2 normal ranges. And it just has to do with it's Chevy versus Ford. We're using a different assay. And there's a potential for incredible confusion if education is inadequate. And that's why I'm here today, is to make sure that before the launch happens, everybody's heard about it, everybody gets comfortable with the algorithm and understands that we expect there to be some confusion, and there's pathways to settle it. So this slide just shows that if you have a very low high sensitivity troponin, your prognosis. This is years, this is all-cause mortality. If you have a low troponin, you live forever. If your troponin is higher, your risk of dying in the next 5 years is higher, just like standard troponin. So here's the algorithm, and I'm going to spend a few moments going through it because this is probably one of the most important things that you understand from the talk. And so I have to put on glasses so I can see it. So again, this is the acute chest pain protocol. And what's important is there's a time zero. So you get to the emergency department, we get a troponin. And then 60 minutes later, you get a second troponin. And this is critical for the nurses. Their window to get this is tight. So I don't want a 58-minute troponin because I don't know what to do with it. It's going to be 60 to 75 minutes after that one. Okay, so nursing education is huge, and this is the biggest change in their workflow. We're going to incorporate a risk score that I'm going to talk about and remind you about it in a few minutes. And then most people are able to get a disposition at that point. There is the possibility that there will be some people that will want a third troponin, and so part of the algorithm will allow a 3-hour troponin if you're sort of confused. So somebody presents with chest pain. We'll go this side of the algorithm first. These are the numbers at Rochester Regional. Less than 76 for a male, less than 51 for a female. And it just has to do, I can't say enough good about Dr. Vargas and the lab medicine people, is we work very closely together with them to make sure that we agree with what the algorithm, the values are. And there really is a difference between males and females, mostly based on size, but there are other difference besides that. And so there will be sex-specific cutoffs. So I'm going to go through the left-hand algorithm first. So these are normal. Going to the leftmost, the 1 hour, we're looking at the change in high sensitivity troponin. Again, will be a difference for male and female. So if you're a male and it goes up more than 15 or more, that's abnormal. A female, if it goes up 10 or more, it's abnormal. So if you were normal, it's now positive, you have ruled in. And what I want to make clear here is you've ruled in for a possible acute coronary syndrome. You've not ruled in for an MI, you've ruled in for something, and more work is needed, you get admitted, okay, and figure out what is going on. The branch next to that one, so you present with normal, the delta is negative, it's not going up, you have ruled out. This is where the heart score comes in very handy. So if you have a low heart score, and we're clumping people into low versus intermediate high, so they're branches differently. So if you're low, like Julie was, with a heart score of 1, you go home with appropriate follow-up to figure out what was going on. If, on the other hand, your normal doesn't go out, you've ruled out, but you got a lot of risk, these are the people that go to OBS and you kind of figure out what's going on. So those people are not going to just go home. They're the people that would go to OBS now. They're going to still go to OBS. I'm sorry if my picture is blocking some of this. It's kind of blocking it on me. But anyway, so now on this side of the algorithm, if you are positive on arrival, that's not normal, but it doesn't say you had an MI either. It's something is abnormal. You got to look at the 1 hour, is what the delta is. So if the delta is low, it probably is not an MI, but something is going on because your troponin was high. So these people get observed. Again, the algorithm is going to vary between whether somebody is a low probability or a high probability person. They're going to go to OBS. This is where the 3-hour troponin sometimes is helpful. So say the first was 100 and it went up by 13. And you say, well, I don't know, let's get another troponin at 3 hours and just see what's happening. That would be an appropriate thing to do. The others that are obvious, so you're come in high, it goes higher, you've ruled in possible ACS. Again, remember, possible ACS. There is a differential diagnosis always. So you're going to see this algorithm over and over, and there will be laminated cards that you can keep with you if you'd like. So what's the heart score? Very validated score, has been around for years and years. H is history, E is EKG, A is age, R is risk factors, T is troponin. So in each of those segments, you get either 0, 1, or 2 points. So if the history is like hers, sharp stabbing, it's very low suspicion that she gets 0 points for that. Moderate suspicion, high suspicion. EKG, same thing. She was normal. She gets 0 points on the heart score. If it's not specifically abnormal, you get 1 point. If it's showing ischemia, you get a couple points. She was less than 45 years old. If you're like me, you get 1 point. If you're older, you get 2 points. Risk factors, no risk factors, you get 0. 1 or 2, you get 1 point. 3 or more, you get 2 points. And one of the risk factors, so the 5 standard ones include cholesterol, hypertension, diabetes, smoking, family history, but the heart score also says if your BMI is over 30, you get 1 risk factor. And then the troponin. So a negative troponin is 0, a little elevation is 1 point, and then a high is 2 points. So you just add it up. If you're 0 to 3, you're low risk. If you're 4 or higher, you're intermediate or high risk. So one of the biggest problems we all have is what to do with these low positive troponins. And this is where you need to be a clinician. You need to think a little bit. You don't just base on a lab test. So what is the pretest probability? You know, if you have somebody with typical pain, chest pain onset in the last 2 hours, ST segment depression, a minimally elevated troponin, gives you a positive predictive value for MI of 90%. So, you know, what is the pretest probability? Again, alternatively, Julie, atypical chest pain, recent onset, but no EKG changes, the pretest probability is actually quite low. Then think, you know, is there another readily identifiable cause? And this is where the differential is so important. Are there other causes that could cause a mildly elevated troponin? And then thinking, okay, what other tests will help me sort this out? And that's where sometimes a 3-hour troponin would help. An echo is often helpful. Get BIPL involved with some other funky stuff sometimes. Again, be a clinician, think about, you know, cast a wide net early on. And this again is my second most important slide, is there is a differential diagnosis for an elevated troponin. And aortic dissection is one that people don't think about enough, but have it high in your list. Tachyarrhythmia will do it. Almost all people coming in with acute heart failure are going to have some elevation of troponin. Any of the itises are going to have an elevated troponin, severe LVH, infiltrative diseases, stress cardiomyopathy, the troponin curve can look identical to an MI. Trauma, obviously, and iatrogenic trauma, surgery, stents, ablation, you're burning tissue. Cardioversion, you're frying. Somebody who's had more than a couple of beats of CPR almost for sure has trauma to their myocardium. Rhabdo can do it. So these people who come in with CKs 10,000, you know, if the troponin is a little elevated, well, you kind of expect that. Burns, our cocaine friends, folks getting chemotherapy. This time of year coming up, carbon monoxide poisoning, we may see some of that, and the troponin is going to be positive. Obviously, we have to watch out for scorpions and jellyfish around here. Other things, PE, again, when I hear chest pain, to me, it's MI, PE, or dissection every time. So keep those two very high in your differential. ARDS and COVID patients have positive troponins. septic shock, severe anemia, stroke. Almost all big strokes have a positive troponin, CKD, and strenuous exercise. So anybody who's ever run a marathon has had a positive troponin. So again, cast a wide net. Remember, there is a differential. I want to just mention Care Connect. Right now, there are multiple chest pain troponin things that are out there. We are going to one inpatient order set for troponins. There's just going to be one way to do it. It's going to be the same across the system. Initially, you were not going to be able to get an outpatient troponin because for chest pain, there is no role at all, even a little bit, for a troponin with somebody with acute chest pain. If you have somebody that you think you should get a troponin on, you need to think about getting them to the emergency room. Unfortunately, COVID hit, and there are COVID patients that it makes sense to get a troponin on. So there will be a COVID troponin panel that you can do. And I do want to acknowledge, you know, I'm presenting, but this is the work of dozens and dozens of people, and really a big team effort to get this rollout there. So again, the rollout is going to be one time, everybody across the system. Standard troponin at that time is not available. Don't ask for it. You're not going to get it. So the timeline. So we've been working on this big team for over a year. First, we needed to make sure that cardiology liked the idea and where we were going. Our emergency medicine colleagues were huge in helping us push for this because they really wanted it too. The hospitalists have been fantastic in buying into this. And after I gave a talk a couple weeks ago, and I had all these hospitals come up to me, and it's like, oh, we're ready, let's do it. And then we had to get the lab. So we were actually ready to pull the trigger around April 1st, but COVID came and caused us some problems. And obviously that became the system's priority. Now that we're in between waves, we were going to launch it today, actually. And so September, October, big education time, and that's what we're doing right now. Turns out the order set build is a bigger thing in the COVID era than I had anticipated. And when trying to do lab in 5 different hospitals, it's actually more complicated. We have it in 4 set ready to go. The 5th is a problem. So it's not launching today. My maybe launch for this is right after the first of the year, but it will be when Care Connect is 100% ready, the equipment is ready everywhere, and I feel everybody, especially the docs, the APPs, and the RNs are 100% have had the opportunity for education. So the key again is the clinicians, the nurses, and again for the nurses, the big deal on them is getting into their workflow the 0 and 1 hour troponins. That time is critical to make the right decisions. Okay, so the rest of the talk is interactive. I've got 9 examples, and all 9, these are going to be your top, your choices. So why don't we practice the system, Brad? So you get to vote A, B, C, D, or E. So you're going to vote stat to the cath lab, send the patient home, get a cardiology consult, get any blood test that you'd like, you know, a serum, acorn level, anything you'd like, or any imaging test that you'd like, PET, MRI, something.
So Gerry, you want to pause for a second and take the couple of questions that you have?
Well, just test the voting system real quick. Okay. I want everybody to vote. Right. And again, there's no right or wrong here because we're just testing the system.
So just pick anything and vote on it? Okay, yes. The results, okay, the polls up there, please pick one choice. So it says polling is closed, relaunch poll. Okay, there you go. You have 135 participants, and 71 of them voted, and you got a
So what
display
won?
of the results there. I'm gonna end polling and share the results. And there you go. Can you see them?
I love you guys.
All right.
Back to the cath lab. Good, good, good. Perfect. Thank you. Okay, let me take a couple questions, Brad.
So there was some question on the difference between genders and why that is, and if someone is changing male to female on hormones or with surgery, et cetera, how would you react to that?
Yeah. So again, it is just the laboratory medicine has tested this on thousands and thousands of people and came up with the normal ranges, and that there clearly was a difference between men and women. I think size is part of it. And again, I would use the sex that the patient tells you they are. So if they change to a woman, they're a woman.
Yeah. So is there any scenario in which you would adjust for size? So if there's a
I would not. There's not a literature to say to do that.
So the next question is, based on experience at URMC, what impact do you expect on observation volume, number of admissions, et cetera, length of stay, what?
Yeah, so good question. I expect that there will be less of the Julies in the OBS unit. They're going to get out faster, but it is a more sensitive test. And so you are going to pick up some of these gray zone people who in the past we missed that really have something going on that needs to be worked up. So I believe people, I think overall, when it's been looked at in like countries, the number of people going to cath early goes up a little bit. The number of people going home early goes up a lot. And then a lot of decision making in the middle.
So Dr. Sham asks, troponin sometimes checked for cardiac amyloid, so perhaps you shouldn't restrict it to acute settings only.
So I shouldn't restrict it to what?
If you restrict the test to acute settings, then people who are monitoring things like cardiac amyloid, those are chronic things done in the outpatient setting.
So I'm not actually aware of serial troponins being used to follow that. So again, happy to talk to you about it, Ron, offline. And yeah, again, I don't want to hurt patient care, but nobody's brought up a situation where serial troponins are used prognostically.
Okay. If the initial troponin is less than 51 or 75, but the delta is greater, still remains less than 51 or 75, is that considered significant?
Correct, yes. So that's exactly right. So a delta that's still below the limit is, delta that's positive is positive, and that person has something cardiac going on.
Sure. Okay, you're on. Keep going.
Good, beautiful. Yeah, great questions. Thank you, guys. Let's see. Okay, so what happened to my full screen? I don't know what happened to my full screen. We're going to keep moving though. So first one is a guy named Sam, 48 years old, intermittent chest pain. Most of it's been with exertion. His past medical history, he hasn't seen a doc since his mom took him to the pediatrician. His EKG is there, is normal. His initial troponin was 22. His 60-minute troponin was 38. So the exact scenario that somebody just asked, delta is 16. Heart score is 1. So negative first troponin, delta is positive, heart score of 1. Please vote. Good, I agree with that. So this is a person, why isn't it moving now? There we go. So this is a person who falls down this pathway. So normal to start, delta is positive. They've ruled in for something. He may be having acute coronary syndrome, but the right answer is not take him straight to the cath lab. You know, you're gonna get to know this guy a little bit, see what his hemoglobin A1C is, see what his cholesterol is, start figuring what his risk is, get to know him a little bit, he hasn't seen a doctor forever. Is he gonna show up for follow-up? Because all those things matter. And I think getting us involved with that patient makes good sense. So I agree with the consensus. Second one is a guy named Leon, 58 years old, 2 hours of having a truck sitting on his chest. He's a hypertensive smoker. There's his EKG. His troponin is normal, and his heart score is high. So again, same choices for all 9 examples.
I think you got your answer there.
Yeah, exactly. So yeah, that's an acute anterior infarction. Nothing changes. The troponin isn't part of the algorithm of how we treat an acute STEMI.
So Jerry, there was a question about, is being a male no longer on the heart score?
Being a male is not part of the heart score.
No.
Correct.
Right.
Okay. Next one is Andrea. She is a 62-year-old who presents with shortness of breath and chest pain. She's got stage 4 breast cancer, undergoing treatment. There's her EKG, which shows sinus tachycardia. She has an incomplete right bundle branch block. On arrival, her troponin is elevated. And at the 1 hour draw, it's elevated further, a delta of 60. And she has a heart score of 3. Same choices.
This one's interesting. You got some disagreement going here.
I know. I don't make them all easy. Come on.
All right. So there are the results.
Okay. Interesting. So the E's were the right one. So this is a patient that clinically has a pulmonary embolus. And so I think a CT would be the right test to do. Is it inappropriate to take her right to the cath? Probably with that history, it would be inappropriate. There's certainly the EKG could be, but somebody, acute chest pain, shortness of breath, undergoing cancer treatment with a classic PE EKG probably is the best. And again, the C's, I love you guys. We're happy to be involved every time. And one of the things that's going to happen early on, especially until everybody gets comfortable with this, give us a call if there's confusion. And so I don't think C is wrong, but I would get the CAT scan. Let's see if I can stump you guys again. Just come on. There we go. So again, she was in this pathway here. So she was positive, so she's ruled in. But what I want to emphasize is she's ruled in for something. She's not ruled in for an MI. She needs further testing. Okay, how about Maggie? Maggie's 42, again, shortness of breath, fever and cough. Her COVID test comes back positive. Past history is a couple C-sections. Here's her EKG. It's normal except for being at 102. Her initial troponin is high. Her second troponin is high, but the delta is only 8. And she has a heart score of 0.
Okay, you got more than half the people to respond, so that's good. I'll end it there.
Good, good, good. I agree with that. The patient has COVID, obviously. She's COVID positive. Her symptoms are consistent with it. As everybody knows, after lungs, the heart's the next most affected organ. And I think she's somebody that not acutely, but down the road a little bit as she recovers, needs an echo to see if her LV function is deteriorating. I think the clinicians taking care of her need to be very wary that that this could turn into, you know, full-blown myositis. So be careful with her. But I agree. I would get an echo. We probably wouldn't do it acutely, just because we want to minimize exposure to our echo staff. If there were a clinical indication other than a troponin, we would be obviously happy to do the echo. So again, she falls in this arm of the algorithm, elevated, delta is small, there's something going on. So she would come down this limb. So again, these are just trying to illustrate how to use the algorithm. This is actually my brother. He's 70 years old, lives at St. Anne's, woke up one morning with chest pain. And he has schizophrenia. He has a history of hypertension that's well treated. He has paroxysmal atrial fibrillation on apixaban. So he comes to emergency. He's in rapid AFib, no acute changes. They zap him back to sinus. And this is where it gets theoretic, because we obviously don't have high sensitivity troponin yet. But on arrival, they drew one and it was 45. And an hour later, it was 68, giving a delta of 23. And Mark's heart score is 4.
Okay, I think most of them want a cardiology consult, Jerry.
You're lucky, because I was sitting right next to him. Even though family isn't allowed in the ED, this is a real story. I did B. I sent him back to St. Anne's. The thing about it is, again, have a differential. Getting a cardiology consult is not wrong at all. And this could be an acute coronary syndrome. The example I gave here is that if you do a cardioversion on somebody, your troponin's going to bump a little bit. So in the future, if Mark were to come in with this, so what we actually did is he had a first troponin that was negative. He then sat in the ED for 6 hours for the second troponin to come back negative. So I had ruled out acute coronary syndrome, and then we shocked him and sent him home. In the future, again, it's a 1 hour wait instead of 6 hour wait to do the zap. If you're concerned about acute coronary syndrome, don't zap somebody who is hemodynamically fine until you get the second troponin back in an hour. So yeah, it was kind of a fun one. And so, yeah, again, he kind of went down this line here, didn't he? And possible acute coronary syndrome. The difference is obviously that he had the zap, which is why his would have been positive. Okay, how about Wanda? His chest pain earlier in the day, hypertension, smoker, stent in the past, so she's got known coronary disease. Her EKG shows old inferior infarction. First troponin is normal. 1 hour troponin delta is 0. High heart score.
Okay, you got all over the map there, but cardiology consult still won.
Never a wrong answer. This we can either get involved at that point, or it depends how much the chest pain bothered you. It might not be inappropriate to do a stress test first and then involve us if it's positive. But either one of those, she needs either imaging or a consult, who would probably suggest again that we get a stress test. Come on. So again, she's falling in this category here, where she's ruled out, but she's actually intermediate probability. So she needs further thought. And again, I think a consult is fine. I think admitting to OBS, doing a stress test, normal stress test, send her home for follow-up, abnormal stress test, you involve us. Either one of those I think is very appropriate. Okay, common thing that we see, 78-year-old with chest pain while on dialysis. So hypertension, dialysis, diabetes, LVH, again, very common patient we see. Time 0 troponin is normal, abnormal, excuse me. Time 0 troponin is abnormal, but the delta is actually going down. But Charles has a very high heart score. So high heart score.
Okay, got another spread here.
Yeah, and as they should. Again, I didn't just give you softballs. I gave you guys hard questions, and they are. And I think that is the right answer, is to get a cardiology consult, and we'll help you sort out the way to go down that algorithm. Unfortunately, end-stage renal patients, if they get a troponin drawn, it's gonna be positive. That the guy's got LVH, he's on dialysis. It's gonna be elevated. So you're going down this path here. So it's elevated. It's going down, not up. So your high probability. The diagnosis here is not really obvious. And what I would do if I was called in is talk to him about his chest pain, look at what his previous ischemia workups have been, and make a decision from there. Obviously, this is a guy who almost for sure has some degree of coronary disease. If he was cathed 2 months ago, I would probably not cath him again. If it's been 5 years, he might need it. So get us involved in that guy. And then this one, yeah, 64-year-old, chest pain, diaphoresis early in the day, diabetes, hypertension. There's her EKG, it shows LVH and T-wave changes here, depression's here. First troponin is high, second troponin is higher, heart score is 5. And this one's a little tricky, so I'm gonna warn you, think a little bit before you vote.
Okay, I guess people are reluctant to vote because you said that.
The chickens.
There you go.
Oh, I got you. So the
Cath
C's
lab.
are right. So this is a normal end STEMI. It was not an ST segment. And the reason I said it's tricky is there's no reason to take this person's stat to the cath lab. Okay, so she's got a non-STEMI for sure. She's likely to have coronary disease, but she's hemodynamically stable. Pain is gone. There's no reason to go stat to the cath lab. So you don't call the interventionist and say, I got to get this person in the lab at whatever time. Get us involved. She is going to get cath, just not stat. Gotcha. Okay. Now, I got to warn you. This is the trickiest one. It's my last one. It's number 9. Anybody who gets this one right, Prad gives you a gold star. So 68-year-old admitted to 5200 for Tecousin therapy, who had the sudden onset of substernal chest pain. Past history is diabetes, atrial fibrillation, coronary disease stent a decade ago. So here's her AKG, AFib, rapid response, poor artery wave progression, but luckily no acute changes. So her initial troponin is 30, which is negative. Her 1 hour troponin is 37 with a delta 7, which is negative. And she's got a heart score of 5. Same options. Last one, gold star available from Prad.
Okay, you got quite the spread there. Someone has to be right.
Okay, let's see how many gold stars. 20% of you get a gold star. D is the right answer. So, and again, this one was meant to be hard and to be tricky and to bring out 1 point. So this is an acute chest pain algorithm. It works for somebody outpatient coming into emergency room. And the reason for this one being different is when somebody's outpatient comes in, there's an inherent delay from when the patient started having symptoms to they decided to activate to the system till they got here. On 5200, our nurses are very facile at getting help. So help is at this person's side within minutes. And this is somebody that is low, has ruled out intermediate probability. I would get a 3-hour troponin. That's where the 3-hour troponin comes in helpful. And on inpatients, especially, or somebody who says, I was driving on 104 when I started having chest pain, pulled right in, I might do a 3-hour on that person. So in this algorithm, the 1 hour fails if somebody is seen ridiculously fast. Okay, so you guys did great. I appreciate the number of people who did chime in. I like it to be interactive. It's telling Pratt earlier, the hardest thing about a Zoom grand rounds is I can't see your faces. I can't see who's, checking emails or whatever. So 5 key points. Know the differential diagnosis and always have it. So cast a wide net first. It isn't this person has an MI and you're going to miss other things. At a minimum, positive, always think PE, always think aortic dissection, always think MI at a minimum, but keep a wide differential. Use all the clinical information. You guys are clinicians. You are not lab analyzers. And then you get the quantitative baseline is very important. The delta is what is really important. Is the delta positive or not? And then understand what the appropriate workup. And again, we do understand that there's going to be a lot of nuance that goes on. That's what these cases were expected to show you guys. Feel free to curbside us if it's something that we think needs a real consult. We'll say that needs a consult. If it's something that's like, oh yeah, just do this, I'll tell you, just do that. And with that, I will take more questions.
Yeah, so there's a there's a couple of questions there. Dr. Chaudhary asks, what kind of changes of high sensitivity troponin levels at 3 hours would be concerning? I think this question was actually asked before your last case, but
Yeah, no,
you answered a
perfect.
little of it.
A great question, and it's exactly the same numbers. Greater than 15 in a male, greater than 10 in a female. So what the delta really is doing is every test, as you know, has noise. And so a troponin delta of 7 is considered within the range of error of the test. If it goes up in a male more than 15, that's not just in the range of error, that is something going on. In a female greater than 10, that's not just random variation and test error, that's a real abnormal. So great question. Same delta at 3 hours. And it's delta from the first one. So the time 0 is what's important, and then the delta at time 3 hours.
Okay. And D. Jackson asks, were Leon's troponins normal?
Oh man, I don't remember who Leon was. Which one was Leon? These are all made up names except for my brother. Oh, the MI. So yeah, when somebody has only 2 hours of chest pain, his first one is normal. I didn't give you a second one. It's going to be 4,000 with this EKG. And with the high sensitivities, again, the numbers, I've given you all pretty low numbers. This guy's second troponin is going to be astronomical in the many thousands.
So Mike Myers says he's probably going to need a refresher by January.
One of the things that we are going to do is we're going to have this in a laminated pocket card for anybody. So that will be very, very available. I'm going to clean up this section of the card a little bit. That's why they're not given out right now. Again, the delay is giving us more time to think on how to just clean this up a little bit. Yeah. But Mike, I'm always happy to do a private tutorial. Again, curbsides are welcome. Happy to talk to you guys anytime. And again, if you ever have any trouble getting a hold of any of my colleagues, my cell number is 732-3099, 732-3099. Call me directly, and I want to know about it if somebody's not getting good service.
So since we have a minute, I'm going to re-ask Dr. Sham's question in a different way because it's on my mind too. So the infiltrative cardiomyopathies, like amyloid, will sometimes use troponin levels as an indicator that there's cardiac involvement, not to monitor, but just to tell us in someone with systemic amyloid that we're dealing with cardiac involvement.
Yeah, so just get the standard panel. Just do the standard panel, then so if it's a one-time thing, just do the standard panel, you get a 0-1 hour, and you got your numbers. Okay. Again, I think in these day and age, you're going to answer that question with an MRI, not with an MRI, not with the troponin.
Yeah, it's a poor man's test, I guess.
Yeah, and again, I have no problem using this algorithm. Again, what we're trying to do is get people away from ordering troponins as an outpatient for chest pain. That is bad medicine, and we're using this opportunity to end the possibility for that to happen within Rochester Regional.
Got it. So we got a couple of comments with kudos for the interactive format. I like that too. I think we put that together at the last minute, and I think that worked out very nicely. We're going to do that for more grand rounds. Thank you.
Actually, yeah, no, I'm all about it being interactive. Again, if it's just to show a bunch of slides, you may as well see what Mayo Clinic is doing. You know, it makes no sense for it to be local.
Yep, sounds good. So I guess that's Dr. Sham again. It sounds like it will be restricted. Is that not the case? So, no.
No. Yeah. So it's just plain not available. You can't order the troponin panel as an outpatient. It's not restricted. Yeah. It's just not there.
Yeah. So, but then I guess in the circumstance where you want to know about cardiac involvement, how would you order it?
So outpatient cardiac amyloid.
I mean, the outpatient with known amyloid where you're just looking for.
It would not make a bit of difference prognostically or diagnostically.
Okay.
If you already know they have amyloid, I wouldn't get it. So again, Ron, I'm happy to talk to you offline. And if there's scenarios, there's always a workworkaround, obviously.
There's always a workaround.
You know, you can call it a COVID, I guess, and you'll get one. But there's always going to be a workaround if you need it. I want to help make sure clinicians always have the tools that they need, 100% of the time. So I don't want to restrict people from doing things, but again, a troponin to follow an amyloid, yeah.
They're not to follow. It would just be to know. So how different is the strong troponin assay?
You know, I don't work over there at all, but I have seen it before. Their numbers are lower than ours. So their normal ranges are somewhere 20-ish, 30th. It's just a different assay, but it's the same. Conceptually, it is exactly the same. They decided to go with 0 and 3 hours, and they don't have a risk score in it, which I think is not a great idea. I want people to be clinicians, so I want them using the risk score, and so I think that's very helpful to us. But their numbers are a smaller number than our number.
Yeah. So Mary Cohen says, how about using the proBNP for the amyloid question? And yes, the BNP is also elevated.
Sure. Again, I must admit, I don't follow amyloid patients, so I can't say.
Yeah. So your heart failure colleagues will need to answer that, I guess.
Yeah.
Yeah. Mike Myers says we need a grand rounds on COVID-19 in the heart. Who would do that? Maybe we include that in one of our COVID-19 updates, do a segment on cardiac involvement.
We would be happy to. This is a good time for me to plug our symposium. I'm pretty sure that is one of the topics in our symposium on November 14th. So Mike, November 14th, you're going to love it. And again, right, if you have the time and want us to do it, we'll put together something for you also.
All right, sounds good. I think we got through enough of this and we're just about out. So thank you very much, Gerry. This was great. Good update.
Very fun. Thank you. And thank you guys for being interactive. Appreciate it.
Yep. Take care.
Have a good day, guys.